Thanks very much. Welcome everybody this morning. Everybody's here bright and early to start with breast cancer. And it's going to be really fast because there was a lot of data on breast cancer at ASCO. I think it's the first time ever in my career where there were 5 press releases even before the meeting about novel data. So what are we going to talk about? So there were a number of different studies presented. We had in early stage disease, HER2 positive, de-escalating therapy. So looking to see whether everybody needed carboplatin as neoadjuvant therapy, and looking at a specific predictive and prognostic test to see whether or not that might help us in that decision. And for HR positive disease, a remarkable 15-year follow-up of soft and text, and an interesting investigator-initiated study that tried to look at escalation of abemaciclib to reduce diarrhea, and then a very cool drug, new drug class, managing hot flashes without hormones, that's going to be up for FDA approval in this summer. And then we'll talk about metastatic disease. I'll go through those topics when we get to that section. So let's talk about the carboplatin and de-escalating therapy for HER2 positive disease. So we know that this is a very responsive subset of breast cancer, and we tend to see high rates of pathologic complete response, particularly in the ER negative HER2 positive group. So this was a trial done in China where they randomized 774 patients who had HER2 positive breast cancer, stage 2 or 3, stratified by hormone status and node status to receive the standard TCHP, the CB being carbo, every 3 weeks for 6 cycles, versus a taxane, trastuzumab, and pertuzumab. You could choose whether you were going to give paclitaxel or docetaxel, and one of the problems with the particular trial is that they gave their taxane every 3 weeks, and we don't give paclitaxel every 3 weeks and believe it's inferior to an every 2-week or lower dose weekly dosing schedule. In any case, they then went to surgery. About a third of the patients were node negative. Most of them were stage 2. And you can see, interestingly, 45% received nab-paclitaxel and a third docetaxel. Only 20% got paclitaxel. So all the taxanes were given every 3 weeks, as we discussed before, and we don't do that for either paclitaxel or nab-paclitaxel. But it was powered well, and the stratification was good in this trial, very well balanced. So as expected, there were more grade 3-4 adverse events in the TCHP arm, more neutropenia because of the combination of taxane and carboplatin, more febrile neutropenia, and particularly, which is difficult for us to manage, more thrombocytopenia and anemia. They had higher all-grade nausea and vomiting, and of course, increased creatinine. What you can see for the pathologic complete response rates, which was the primary endpoint, is they were identical between the 2 arms. 2/3 of the patients had no invasive disease at the time of surgery. The PCR rates were quite high in ER positive. These are the highest rates that have been described, and we don't really know if they included anybody who had 1 or 2% ER positivity. That really is still what we think of as ER negative HER2 positive. And the PCR in the ER negative was what we would expect, a little under 80%. So that suggests that you could actually eliminate carboplatin in at least some patients where you're giving neoadjuvant therapy, sparing quite a bit of toxicity and recovery period. And here are some of the other studies that have looked at overall PCR rates, looking at THP versus the other studies where they had carboplatin, TRAIN, and trifena. And the PCR rates in ER positive, again, a little bit lower in those trials than what we saw in this particular trial, but the PCR rates in ER negative are very similar overall. So can we omit carboplatin from standard neoadjuvant THP? I would say yes, with caveats. We need more data in stage 3 disease where patients have a lot of disease. We need to understand the relationship between ER and HER2, because I've been seeing a lot of patients who are called HER2 positive, but on retesting were HER2 negative. They have very borderline copy numbers and ratios. These patients don't respond in the same way. We don't know what the value of carboplatin in that setting is. We don't want to give our taxanes every 3 weeks because we've been there, done that. We want to give them weekly where they're better tolerated and we believe more effective. So if you're going to do this, we're not giving nab-paclitaxel except for in patients with allergies. I would give weekly paclitaxel. And then the question is, would you extend it out to be the equivalent of 6 cycles where you'd have more risk of peripheral neuropathy with paclitaxel? We've been using cold gloves and booties as a sort of regular approach with compression. So you have to use a a non-sterile glove that's one size smaller than your hand because it works much better with compression and the gloves don't fit particularly well. We'll wait and see what their long-term data is, and also biomarker data. And now we have a whole bunch of other things going on. So how does this really affect us? So if you gave THP and you didn't have a PCR, maybe you could rescue somebody very well using TDM1 or trastuzumab emtansine. We'll see the data in the not too distant future from Destiny Breast 05, which is looking at TDXD versus TDM1. And we believe, of course, that this trial, which is very well powered, will likely be positive, favoring TDXD. But in addition to that, we recently saw a press release from Destiny Breast 11 that looked at giving TDXD, trastuzumab deruxtecan, for 4 cycles, followed by paclitaxel HP type approach, no carboplatin, versus an AC, which a lot of us aren't using very much anymore, followed by THP. The TDXD alone arm closed early. We don't exactly know why, but the DSMB closed it not due to toxicity. So presumably they thought the PCR rates weren't going to be quite as good with TDXD alone. And again, we've used this sequential non-cross-resistant therapy quite successfully in treatment of both HER2 positive and triple negative disease. But this trial had a press release saying that TDXD met the primary endpoint, which was improved PCR rates compared to the AC-THP type approach. So we're going to see that data in the near future at ESMO in October, and we'll see how that influences our approach because, are we going to give TDXD up front? And if we had very high PCR rates across ER-positive disease, where you have some patients who are really HER2 low, they had a ratio of 2.1 or whatever it is, and they're not really HER2 positive. Or are we going to use the rescue approach so that we don't expose all patients to the drug up front? So we'll see, but it does look like we'll be able to get rid of carboplatin. We also saw the secondary results from Compass HER2 PCR. This is a cooperative group trial from the Alliance that looked at just giving THP to everybody with paclitaxel weekly or docetaxel, so they only got 4 cycles, a much shorter course of treatment, very nice, combined with HP as neoadjuvant therapy. And you had to have at least stage 2 disease, but could be node negative. The primary endpoint is long-term outcome, but they look at relapse-free survival is as good as you would expect with a longer regimen. And they look at ER-positive and ER-negative. But their secondary endpoints included PCR. So I've given you a run of the patient population here. Of course, they are generally well people, and 58% 2A, so node negative T2 tumors. And 75% T2, and then node positive a little under 50%, which is probably a little smaller than we see in clinical practice in general. But this is people speaking with their feet because they didn't want to give people THP who had a lot of cancer, right? So they didn't put on stage 3 patients very much. And it's interesting, the ER positive was about 2/3. Again, this is speaking with your feet. Most had true HER2 positive disease. So what they saw was that the PCR rates were quite high, but not as high as that other study, interestingly. Only 33% in ER-positive disease, 64% in ER-negative disease. And they looked at clinical pathologic factors and molecular markers associated with PCR. And what you can see is that the higher your ER was, the lower your PCR chance was. You can see if you were ER negative, the odds ratio is 4.2, whereas if you were strongly ER positive, your chances of PCR went down substantially. So this is actually what we do see in clinical practice. And intrinsic subtyping, HER2 enriched, is much more common in the ER negative population. ER positive tend to be more luminal B, and you can see it's a 2.7-fold increase if you have HER2 enriched disease compared to non-HER2 enriched. So that suggests that we might even be able to choose a less intensive regimen based on these factors to have a better idea of who responds. Weekly paclitaxel worked a little bit better than docetaxel. And then the HER2-DX PCR likelihood score, that this is a scoring system developed by our colleague in Spain, Aleix Prat, and now marketed, looks at 27 different genes, including the HER2 amplicon. And what they saw was that if patients had a HER2-DX score that was high, they had a 64% chance of PCR, low, probably mostly basal-like tumors, 6%. ER positive, again, if they were HER2-DX low, their PCR rate was 63% versus 11% for high. Well, the PCR rate there is 58% if they were high, 18% if they were low. This is the percentage of patients. Sorry, I need to put my glasses on to see that better. But so the PCR rates were clearly much higher if you had a HER2-DX score that was high. So we don't know that this is regimen specific, but it does suggest if you had a HER2-DX score that was high and the clinical pathologic factors, that you could choose a less intensive regimen and give people just 4 cycles of chemotherapy, and that would be it to finish their entire treatment in early stage HER2-positive breast cancer. So we still know that the ER-positive rates are low, and we need to understand the rescue. I do think that the Ascent-05, DESTINY-Breast05, looking at TDXD versus TDM1 will be really important because I expect that we'll have better outcome in the ER-positive, HER2-positive patients with TDXD since it works in patients who really don't have HER2-positive disease. And that we really need to be individualizing therapy even now for our patients with HER2-positive early-stage breast cancer. We can de-escalate therapy in a number of patients and achieve the same outcome. So this is a fabulous trial. It was an international collaboration, text and soft, in our largest cohort of patients with breast cancer, hormone receptor positive disease. The US type approach is the soft trial, where we looked at does ovarian suppression, is it better than not giving it? So TAM versus endocrine therapy with ovarian function suppression. And then asked a second question of tamoxifen versus exemestane with OFS, which was the sort of ex-US question of the text trial. You need OFS, is tamoxifen or exemestane better? And so the AI question really is looking at the cohort of patients where we combined and conquered here of patients who had ovarian function suppression. Is exemestane better than tamoxifen or not? So the median follow-up in the combined group is 13 years, and this is really great. For text, you had to, if you got, you started the ovarian function suppression right away. For soft, if you were got chemo, you had to recover ovarian function before you were randomized on the trial. We participated in both trials. So if you look at overall survival now, which is really a remarkable endpoint in these patients, because our patients with ER-positive disease, even who develop metastatic breast cancer, will live a long time from diagnosis of metastatic disease in general. And what you can see is that if you looked at the no chemotherapy cohort here versus the prior chemotherapy cohort, you can see that the patients who had prior chemotherapy, indeed, the providers guessed well. Those patients didn't do as well, but there was a 4.3% benefit using exemestane versus tamoxifen, and a benefit between tamoxifen OFS versus tamoxifen was not really existing. It was only 0.3%. But it does suggest in these premenopausal women, median age of 40, that exemestane and ovarian function suppression in the higher risk group is more effective, not just on distant recurrence-free survival and the invasive disease-free survival, but on overall survival as well. We also have seen data, this is actually from ASCO 23, that looked at patients who have our best prognosis ER-positive disease, luminal A. But if you looked at patients who are less than 40 versus 40 or older, what you can see here is that the patients who are younger don't do as well. And they don't do as well in rather a striking way in this subset analysis. They just ended up with more, in younger patients, have more luminal B and nasty subtype disease. But they also, even if they're luminal A, they have a worse outcome. This is for reasons we don't understand well, but in part it has to do with the environment the cancer is growing in, biomarkers we're not identifying, and probably the lack of use of ovarian function suppression in a subset of patients, because they looked at all patients here. But even the patients who got the most therapy didn't have as good an outcome. So 93% of patients who were less than 35, 241 patients, had prior chemotherapy. You know, I think this reflects the higher risk disease that patients turn up with, more node positive, larger tumors, more high grade disease. But what you can see here is really a remarkable difference in patients who were breast cancer free or surviving. 14.4% improvement in overall survival. I mean, this is remarkable. We almost never see this in anything we do in terms of treatment, and an 18% improvement in breast cancer-free interval in a group of patients who aren't going to die of other causes. So I think that this is really compelling. We had seen great data from this even at 10 years. This should be practice changing. And then if you looked at the subgroups, you can see with distant recurrence-free survival and overall survival, distant recurrence-free interval, that if you look at the percent benefit just on that black line on the right-hand side, you can see how much it goes up as you are younger, right? So the benefit in older patients is going to be less of adding ovarian function suppression and even alternative endocrine therapies. And if you look at the no chemotherapy cohort, there's no benefit in giving more aggressive endocrine therapy. So if you have better risk disease. And then they did a last analysis here, which I thought was striking, looking at grade. And if you look at the grade 3 patients who had grade 3 disease, they have a remarkable improvement by getting more aggressive endocrine therapy. So OFS plus exemestane, 8.4% improvement in SOFT with grade 3 for overall survival, and 4.5% in text where everybody got OFS up front. So again, very compelling data. And if you look at grade 3 in breast cancer-free interval, it's a 12% improvement by using exemestane versus tamoxifen. So high risk impacts benefit. Grade 3 tumors, younger women, and women under the age of 40 is where I've translated this under 35-year-old data. And there are continued breast cancer events at 15 years plus in these patients. So we do need to optimize their therapy early. There is a carryover effect. What you do, you put your best foot forward, the first. So what you do up front impacts their outcome 15 years out from diagnosis for these young patients. So if you, on the other hand, have a small, low-risk grade 1 tumor, low grade, those patients did very, very well with tamoxifen alone, and in some cases with tamoxifen and OFS. So, this look at whether they're going to get another cancer in 20 years may be impacted by using a short course of ovarian function suppression that we're going to need to wait longer to look at. Now, the hot flashes really bother our patients a lot. This is a big issue, and there's a drug, elinzanetant. These are drugs which are made to be really difficult to pronounce. So someday we'll have a brand name for this too. So there's a thermoregulatory center in the hypothalamus. It's innervated by these KNDY neurons, and they express estrogen receptors. It's really fascinating. So you get these neurokinin 3 receptors that are upregulated in the setting of low estrogen, so in menopause or our treatment, and then you have hyperactivity of these KNDY neurons, and that causes hot flashes. So elinzanetant is a dual NK1 and NK3 receptor antagonist, the only one of its kind. It's been tested in non-cancer patients in the OASIS trials and showed remarkable efficacy. So here they looked at 474 patients, mostly with breast cancer. They could have been high risk, but almost all had breast cancer. And they were randomized 2-to-1 to 12 weeks of elinzanetant or placebo, and then all arms crossed over received elinzanetant for 40 weeks, and they could extend for 2 years. And what you can see here is the mean change in baseline vasomotor symptom severity. They had to have vasomotor symptoms, right, to go on the trial. And the blue, the light blue, is a placebo, and the elinzanetant is the dark blue. And you can see how dramatic the impact was of taking elinzanetant on hot flashes and at all weeks. And it started really early, so as early as 1 week after starting drug. And for patients who've taken fezolinetant, which is a single neurokinin inhibitor, people have really felt it was a game changer when it works. So this was quite intriguing. And here you can see the placebo-controlled period and the massive difference starting at 2 weeks, really 1 week in these patients from taking this drug. The side effects are quite minimal, a little bit of somnolence and diarrhea, fatigue, but the FDA review is planned this summer, and I think for our patients, the financial aspect of it is the only real deterrent, which is that insurance doesn't like to pay for it until you've failed the generic drugs, the antidepressants and gabapentin. Fezolinetant, I was mentioning, is a drug that is available to us. It's only NK3 receptor antagonist. It can cause liver function test abnormalities. Early on, people thought it might cause cancers, but that doesn't seem to be the case. And there is a phase 3 trial enrolling for those patients, so big improvement. So briefly, there was a study looking at escalating adjuvant abemaciclib, 50 milligrams for 2 weeks, 100 milligrams for 2 weeks, and then 150, all BID. More patients were taking the full dose at 12 weeks who had done the dose escalation than what you would have expected. It wasn't randomized from what's reported. I think most of our application to practice is to start with 100 milligrams twice a day for the first month because you have to write a new prescription, and then the second month go to 150 twice a day. And this may allow patients to better manage the diarrhea and symptoms associated with abemaciclib, of course with appropriate education. And there is some talk about having a starter pack potentially for patients. And then the DARE trial looked at ctDNA, and this is an interesting trial. I see I'm not going to have time to go into it in detail, but patients who developed ctDNA, evidence of ctDNA, like using a Signatera assay, with high-risk early-stage cancer. So they limited it after the initial group of patients had very low rates to patients who had 4 or more positive nodes. And in that group, they had a very low rate who had, they were testing over 500 patients. They ended up with 32 patients with serial ctDNA who were randomized to either change to fulvestrant and palbociclib or continue on their AI alone. And what they found was twice as many patients cleared their ctDNA at 3 months, and only 1 out of 9 who stayed on their therapy. Still, I thought it was kind of interesting that 1 patient did clear their ctDNA, whereas 6 of 10 with increasing levels. The screen positive rate is so low, we really need to look at some of these more sensitive assays that will be coming out later this year, and there are multiple studies planned looking at ctDNA. At the moment, it's not ready for clinical practice and shouldn't drive treatment choices because we just don't have enough data on outcome. So let's move on to metastatic disease, ASCENT-04. We saw the first data from an antibody drug conjugate in the first-line setting in patients with triple-negative disease, PD-L1 positive in combination with pembrolizumab, and a small trial looking at another TROP2 ADC called sacituzumab tirumotecan that's in phase 3 trials now. We saw DESTINY-Breast09 exchanging our standard first-line approach with THP with the antibody drug conjugate TDXD, and changing therapy based on molecular evidence of resistance, and VERITAC-2, another oral SERD that showed efficacy in the patients who have ESR1 mutations. And then these quick summaries of the overall survival with the triplet of inavolisib, a PI3 kinase inhibitor, with palbociclib and fulvestrant in patients who have early relapse and evidence of a PI3 kinase mutation with metastatic breast cancer. So they relapse on or within a year of their adjuvant endocrine therapy, a remarkable improvement not just in progression-free survival, but also overall survival using a triplet versus a doublet approach approved by the FDA. And then we reported data that it's safe to re-challenge in a real-world setting after recovery from grade 1 ILD with TDXD with very long clinical benefit out to almost a year. So we've seen data from 2 phase 2 trials in the first-line metastatic setting that giving an ADC, a TROP2 ADC, with a checkpoint inhibitor, regardless of PD-L1 status, resulted in remarkable response rates, 77 to 79%, that were very durable. And again, this was regardless of whether or not patients had a PD-L1 positive disease in the Dato-DXd durvalumab Begonia trial. So ASCENT-04 looked at randomizing patients who had relapsed at least 6 months after their last treatment with curative intent and had PD-L1 positive using the combined positive score, metastatic triple-negative breast cancer. Almost 450 women were randomized to receive sacituzumab or the standard chemo from KEYNOTE-355, a taxane or gem carbo with pembrolizumab. And then the primary endpoint was PFS by blinded independent central review. And you can see that in the group, about a little under 40% came from US, Canada, Western Europe, where these drugs are available in the second-line setting. The chemo had to be selected prior to randomization, about half taxane, half gem carbo. But only 4 to 5% received prior immunotherapy, and that's a really big issue because now everybody we treat in the early stage setting gets pembrolizumab if they have at least stage 2 disease in the neoadjuvant setting, because we've had this remarkable improvement in overall survival regardless of PD-L1 status. So quite interesting, and has to do with the fact that more than 50% of the patients were treated outside of Europe and US, Canada. You can see that there were most of the patients, 2/3, had early stage triple-negative breast cancer, so in today's world would have received a checkpoint inhibitor. Progression-free survival was remarkably longer with sacituzumab govitecan versus chemo, going from 7.8 to 11 months with a hazard ratio of 0.65, highly statistically significant, and really remarkable data at 12 months, where often most of our patients are progressing. Here, 50% of patients remained on therapy versus just 33%. And in subgroup analysis, pretty much everybody benefited. There were too few patients who'd had prior anti-PD-L1 therapy to really evaluate that subset of patients, which is that one little box that's that sits on one, because there was such a tiny number of patients who received prior neoadjuvant PD-L1 based therapy. Overall survival has only 26% of the events, which is good for our patients, better therapy options for patients with this really worst subset of metastatic breast cancer. But the hazard ratio at least is to the right side of 1. It's to the left of 1, right? Less events in that group of patients. But they had a remarkable design in this trial, which I think is so important and a model for the future, is that if you had BICR, blinded independent central review progression, you could receive sacituzumab free in the second-line setting, not with Pembro in the control arm. And that's really important because we're really dogged with the fact that people can't get the experimental therapy in the control arm, so we don't understand sequencing. Right? We don't know if you need it up front or you could get it second. And 81% of patients actually who could receive subsequent therapy received sacituzumab. So it will be interesting to see what survival shows. For some reason, because of probably a PC Mac, you can't see the adverse events very well here, but I've summarized them on the next part. Neutropenia was very similar, and diarrhea, you can only see the grade 3, you can't see the other ones, it was a little bit higher. They see more response rates as well, and they didn't see an increase in immune toxicity. So SG plus Pembro is a potential new standard of care because of this really remarkable improvement in PFS in patients who have PD-L1 positive metastatic TNBC in the first-line setting. No cumulative neuropathy, no interstitial lung disease, and the standard toxicities. And we worry about bone marrow suppression, but it was identical with SASI and chemotherapy. No cumulative neuropathy, and the diarrhea we generally can manage by dose reduction and antipropulsive agents. So I think it is really important to think about this sequencing question, although it may impact overall survival in the trials that we're looking at. There are a number of trials ongoing in the PD-L1 negative population, 540 patients, and then post-neoadjuvant trials in patients who did not have a PCR to neoadjuvant therapy with pembrolizumab can be randomized to SG Pembro versus Pembro and CAPE per physician choice. And this trial is ongoing in a number of centers throughout California called ASCENT-05. We had a press release just before ASCO with ASCENT-03 saying that ASCENT-03 also is a positive trial in the PD-L1 negative population, the majority of our patients, where SG improved PFS compared to chemotherapy in the first-line setting. We'll see that data at ESMO as well. So sac-TMT is the third TROP2 ADC that we have, datopotamab deruxtecan and sacituzumab govitecan, and sac-TMT is the third one developed in China. It has a belotecan topo-1 inhibitor, so all the same payloads, a high drug-to-antibody ratio, a little bit different in terms of its antibody. A phase 3 trial done in China had previously shown an improvement in progression-free and overall survival in a heavily pretreated metastatic triple-negative breast cancer population. The OptiTROP trial treated 41 patients in the first-line setting to just see before developing a phase 3 trial, which is currently open and enrolling, where myself and Aditya Bardia are the co-chairs of that first-line trial. And what they saw was very nice response rates, regardless of PD-L1 status, with responses of 71%, and the median duration of response of 12 months. So very nice data presented at ASCO. We have, as I mentioned, Trophus 11. This is looking at PD-L1 negative disease, treating with sac-TMT in the first-line setting with or without pembrolizumab, a really important question about whether or not we could improve the efficacy of the checkpoint inhibitor by giving it with an ADC, which has been shown in preclinical setting, as well as in these phase 2 trials. And of course, the third arm is TPC. This is a large study. There's also a study ongoing in PD-L1 negative hormone receptor positive disease in the first-line setting, and a trial, again, it changed the colors even, in a trial in patients with residual disease. So we have 3 trials looking at TROP2 ADCs in patients with residual disease after neoadjuvant therapy for triple-negative breast cancer. There are a number of sequencing trials ongoing in the US as well as internationally, looking at SG after TDXD, either order, or TDXD and Dato-DXD I've shown here. And I'm happy to send the slides out since we're going very quickly here. So Cleopatra has been our standard of care for metastatic HER2-positive disease in the first-line setting for a very long time. This is the 8-year follow-up, end-of-study analysis showing improved progression-free and overall survival, and remarkably, a cohort of patients who never had disease progression with a median follow-up of 8 years. And this study looked at adding pertuzumab to trastuzumab with a taxane, at that point, docetaxel. We've also seen very good efficacy data using paclitaxel. So TDXD, improved survival in the second-line setting compared to TDM1, improved survival in the third or greater line setting compared to capecitabine in either lapatinib or trastuzumab. So it's very reasonable to move this into the first-line setting, where they compared TDXD and placebo, TDXD pertuzumab, and then standard THP using either paclitaxel or docetaxel. They could have had one line of prior endocrine therapy, but no other treatment, with PFS as the primary endpoint. They haven't reached the endpoint in the TDXD and placebo arm, but it's an interesting group of patients, actually. The 49% were treated in Asia. Again, they don't have the same access to drugs. Everybody has to pay out of pocket. Hormone receptor positive was about 54%, so exactly what we would think, and 50% had de novo metastatic disease. Only 7% had prior pertuzumab, 1% prior TDM1, and only a quarter of the patients had prior trastuzumab. So it's a very odd population compared to the US population, where patients would have received trastuzumab in the early stage setting universally if they had HER2-positive disease. And you could switch, if you didn't tolerate TDXD anymore, you could switch to trastuzumab and pertuzumab after stopping TDXD, but most people stayed on their TDXD until progression, so close to 2 years. Endocrine therapy was allowed after the first 3 months or stopping the chemo. And for the control arm, you could stop the chemo after 6 cycles and continue HP. Surprisingly, again, it may be because of Asia, but it's not really clear. Very few patients received endocrine therapy, 13.5% in the TDXD arm, 38% in patients with HR-positive disease in the control arm. So that's very peculiar. And I think it probably impacts adversely the control arm here. Here you can see this remarkable improvement in progression-free survival, 41 versus 27 months, a 50% almost relative improvement in progression-free survival. And you can see at 24 months, now the people who are on THP have been off chemo for 1.5 years. The people on TDXD are still on a chemo, an ADC. They have almost a 20% improvement in the patients who are free from progression. Interesting about the endocrine therapy impact. They didn't see much interstitial lung disease. 2 patients died of this. Unfortunately, we need to reduce that to 0. And as I said, the treatment duration for TDXD was 22 months versus with pertuzumab versus the THP, where patients were on for 16.9 months, but they stopped their chemo after 4 and 5 months. In general, there were more treatment emergent adverse events with TDXD because you keep getting chemo for 2 years versus not. And I think that that's our biggest issue, is more nausea, vomiting, transaminitis, thrombocytopenia with the TDXD pertuzumab approach, less peripheral neuropathy. So superior PVS, but half of the patients had de novo disease, and even in the pre-treated group, very few patients received prior trastuzumab, and almost no one received pertuzumab, less than 10%. So we don't really know if you need pertuzumab, and it increases diarrhea and toxicity. And the toxicity of continuing this drug over time is really concerning. We don't know if it's because you just dropped the chemo and you're still giving TDXD also. And we'll look and see what happened over time. Looking at what happens after progression is going to be important. And some patients may not have access to TDXD who are in the control arm, so this matters. And we don't know what the right sequencing is for our patients. We also would like to think about a situation where you would optimize your response, not get neuropathy, 6 cycles, 8 cycles of TDXD. Then drop the TDXD, continue HP. Would we get the same outcome, the same improvement in PFS? Maybe if you added endocrine therapy. For the Patina trial, we saw this very long progression-free survival of 29 months, similar to DB09, ER-positive patients who received palbociclib along with their HP in maintenance after a Cleopatra-like approach. Maybe that's what we should be doing with T-DXd. We're studying that now in the international Demeter study. And then there's also trials looking at tucatinib as maintenance or inavolisib in patients who have PI3 kinase mutations known to cause a shorter PFS. So a lot of questions here. And then what about following for mutations? I've sort of run out of time, so I'm going to go through this quickly. I think it's, this is a really interesting question brought up by the investigator-initiated PADA trial, where patients who had rising ESR1 mutations switched to either fulvestrant and palbociclib or stayed on their first-line AI and palbociclib. And they saw a remarkable improvement in PFS, as well as an improvement in second PFS from randomization. So that led to SERENA-6, where you can see over 3,300 patients were screened for ESR1 mutations. They had to be on a first-line AI and CDK4/6 inhibitor, and they had to have been on for at least 6 months to have an endocrine-sensitive population. And this really worked because these were very endocrine-sensitive disease patients. So they had all surveillance. They couldn't have evidence of progression on scans. And what they found was 548 patients had an ESR1 mutation detected. Only 315 patients were randomized to receive a novel oral SERD called camizestrant and continue the same CDK4/6 inhibitor and a placebo versus continuing their AI, get their same CDK4/6 inhibitor and a placebo. So the patients wouldn't have known which arm they were on, which is critical here because they do know they have rising ctDNA with an ESR1 mutation. They used Guardant 360 for this testing. So out of that over 300 patients who were randomized, PFS was much longer in patients who switched, as you would expect because you changed the endocrine therapy. That was 16 months versus 9 months. What was remarkable was the median time to randomization. So patients didn't have to be tested at 6 months. They could join the trial at 18 months after they'd started, as long as their scans didn't show progression. The median time from initiation of AI and CDK4/6 inhibitor to randomization was almost 2 years, 23 months. To finding the ESR1 mutation was 22 months. And there were almost 2,000 patients who never had an ESR1 mutation and just went off study when they closed accrual. And then the other thing that's quite interesting here is that the patients who had been on for almost 22 months, they have an ESR1 mutation. We know the cancers don't respond well to AI. They stayed on for a median of 9 more months, which is really surprising. And so what we're really waiting to see is trying to understand what the variant allele fraction was. Were these the patients who had very little ESR1 mutations? Why did they stay on for 9 more months when they should have had progression? Are we just not capturing progression well in ER-positive disease by scans? And then we saw this fascinating data on time to deterioration and global health status quality of life. Here you can see that the difference was really remarkable after the first paperwork that the patients are filling out online for global health status. You already see this huge separation, 6.4 versus 23 months median time to deterioration, and we don't know why. So we're looking to ESMO and San Antonio to see more data regarding SERENA-6 to understand, was this because the patients on the AI had more pain and they expected not to? What was the reason? Are we just not picking up progression and patients had symptoms very early? And the drug is overall very well tolerated and not a lot of toxicity other than flashing lights when you walk from a light to dark room, which seemed to go away rapidly and didn't impact quality of life. That's called photopsia. So it's really very interesting. First study, changing endocrine therapy based on a molecular marker of resistance, showing an improved PFS. It's going to be reviewed by the FDA. There's a lot of questions about this. It won't happen anytime very soon, I think much later in the year or early next year. And the big question for us now is, would change in CDK4/6 inhibitors further improved outcome rather than keeping the same one? And we're going to be studying that in collaboration with the Uni Cancer Network in France, we hope, in a study that will open later this year or the beginning of next year. Veritech, this is a PROTAC vepdegestrant, showed an improvement in PFS in patients with ESR1 mutations, but not in all patients. Very interesting drug, novel mechanism of action, but very similar to the data we have with other oral SERDs, although it does block the ubiquitinization of the estrogen receptor, and very well tolerated, does not cause flashing lights. Then the quick summaries, Napa 120, I mentioned the survival and the safety of rechallenge after T-DXd. So with that, I'll thank you very much with a hummingbird from Northern California.
Thank you, Dr.